Hello and welcome to our new topic. Today we will discuss the pharmacological management of acid peptic disease. These disorders are among the most frequently encountered problems in both primary care and hospital practice. Although symptoms appear simple, the underlying physiology is complex and involves regulation of gastric acid secretion, mucosal protection, and inflammatory injury. Therefore, rational therapy requires understanding both aggressive and defensive mechanisms of the gastric mucosa. So, let's start. By the end of this session, you should be able to classify drugs used in acid peptic disease, explain their mechanisms of action, recognize adverse effects and drug interactions, and apply this knowledge to select appropriate therapy in clinical situations. The aim is not to memorize drug names, but to understand targets and mechanisms. Acid peptic disorders include GERD, gastritis, and peptic ulcers. Despite different presentations, they share a common pathophysiological basis: injury caused by gastric acid and pepsin. Hence, most treatments focus on reducing acid or strengthening mucosal defenses. Understanding the gastric gland is essential because most drugs act at the parietal cell. Parietal cells secrete acid, chief cells secrete pepsinogen, and enterochromaffin-like cells release histamine. This organization explains why multiple receptor systems regulate acid secretion. Hydrochloric acid secretion by the gastric parietal cell begins with active aerobic metabolism, which generates carbon dioxide inside the cell. This carbon dioxide rapidly combines with water under the action of carbonic anhydrase to form carbonic acid, which dissociates into hydrogen ions, H, and bicarbonate, hydrogen carbonate. The hydrogen ions are then actively pumped into the gastric lumen across the apical membrane by the H.KATPase proton pump, the final and rate-limiting step of acid secretion and the principal target of proton pump inhibitors such as omeprazole. To maintain electroneutrality, chloride ions simultaneously move through apical chloride channels into the lumen, where they combine with secreted hydrogen ions to form hydrochloric acid, HCl. Meanwhile, the generated bicarbonate exits the cell across the basolateral membrane in exchange for chloride via the Cl-HCO3 exchanger, entering the bloodstream and producing the transient postprandial alkaline tide, after which this bicarbonate is later secreted into the intestine in pancreatic juice to neutralize gastric acid, thereby completing the physiological cycle of acid-base balance. Disease occurs when aggressive factors like acid, pepsin, NSAIDs, alcohol, and H.pylori overwhelm defensive mechanisms such as mucus, bicarbonate, prostaglandins, and mucosal blood flow. Drugs either reduce aggression or enhance defense. This concept simplifies all treatment strategies. The initial step in controlling physiological secretion is the release of gastrin from G cells. This acts through its CCK2 receptor on ECL cells to release histamine and may also have a secondary direct effect on parietal cells themselves, although this is not entirely clear. Histamine acts on parietal cell H2 receptors to elevate cyclic AMP that activates the secretion of acid by the proton pump. Direct vagal stimulation also provokes acid secretion, and released acetylcholine directly stimulates M3 receptors on parietal cells. Somatostatin probably exerts a tonic inhibitory influence on G cells, ECL cells and parietal cells, while local, or therapeutically administered, prostaglandins exert inhibitory effects predominantly on ECL cell function. Drugs are divided into two main categories: acid-reducing agents and mucosal protective agents. This classification reflects mechanism rather than chemical structure and helps guide rational prescribing. Antacids are the oldest therapy. They neutralize acid chemically. They act rapidly but briefly. They provide symptomatic relief but do not heal ulcers. Thus, they are supportive rather than definitive therapy. Magnesium salts cause diarrhea due to osmotic action. Aluminum salts cause constipation. Combining both balances bowel effects. Sodium and calcium salts may cause systemic complications and are generally avoided. Histamine strongly stimulates parietal cells. Blocking H2 receptors reduces basal acid secretion. These drugs were revolutionary historically because they targeted a specific receptor for the first time for the treatment of peptic ulcers. They reduce nocturnal acid effectively but are less effective after meals. Hence they are useful in mild to moderate disease but not severe erosive conditions. Generally safe. However, cimetidine has hormonal effects because it interferes with androgen receptors. This can lead to gynecomastia and sexual dysfunction. This teaches an important lesson. Receptor selectivity matters. Cimetidine inhibits cytochrome enzymes and interacts with many drugs. Other agents are safer. Always consider drug interactions in polypharmacy patients. PPIs are now the most widely used drugs because they directly block the final step of acid secretion. They are more effective than any previous therapy. They irreversibly inhibit the proton pump. Because new pumps must be synthesized, effect lasts long despite short half-life. This is a classic example of pharmacodynamic duration exceeding pharmacokinetics. They must be taken before meals because pumps are activated during meals. Maximum effect appears after several days due to cumulative inhibition. Usually safe. Long-term use may reduce vitamin B12, iron, calcium, and magnesium absorption. Increased infection risk occurs because acid normally protects against bacteria. Chronic suppression increases gastrin. Sudden withdrawal may cause rebound hyperacidity. Therefore therapy should be tapered. Omeprazole inhibits CYP2C19 and may reduce clopidogrel activation. Pantoprazole or ribeprazole are safer alternatives. Always choose based on patient context. These are newer drugs. They block the pump reversibly but act faster. They may represent the future of acid suppression therapy. A prostaglandin analog that enhances mucus and bicarbonate and improves blood flow. Particularly useful in NSAID-induced ulcers. However, causes diarrhea and uterine contractions, so contraindicated in pregnancy. Forms a protective coating over ulcers. Works locally without systemic effects. Good safety profile but may cause constipation and interfere with absorption of other drugs. Bismuth compounds are multifunctional, coat ulcers, stimulate prostaglandins, kill H.pylori, and reduce toxins. Black stool discoloration is harmless but important to explain to patients. This bacterium survives in acid by producing urease. It causes chronic inflammation and ulcer formation. Therefore, acid suppression alone is insufficient, eradication is necessary. Triple therapy combines PPI and antibiotics and is the most common regimen to treat H. pylori infection. Combination is required to prevent resistance. This is an example of pharmacological synergy. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!